Very good morning to all my dear students. This is Dr. Durga, working as Assistant Professor from Vinayaka Mission Shankaracharya Dental College from the Department of Oral Medicine and Radiology. Today's topic for discussion is oral manifestations of endocrine disorders. So all the physiological activities are regulated by two major systems in the body, and these two systems are the nervous system and the endocrine system. So these two systems interact with one another and they regulate the body function. So first of all, we'll see what is the endocrine system. The primary endocrine glands are the pituitary, which is also known as the master gland, the pineal glands, the thyroid and the parathyroid glands, the islets of Langerhans, the adrenal glands, ovaries in the female and testes in the male. And these endocrine glands, they play an important role in homeostasis and controls the cellular metabolism. The endocrine system functions by secreting some chemical substances which are referred to as the hormones. And these hormones are chemical messengers. It is released in small amounts from the glands and is transported to the bloodstream, and from the bloodstream it is transported to the target organs or the other cells. So these hormones, they help in transferring the information and instructions from one set of cells to another. So this, when it comes to the endocrine disorders, the hyposecretion or hypersecretion of any hormone can be harmful to the body. Even the slightest hiccup with the function of one or more of the endocrine glands can throw off the delicate balance of hormones in your body and lead to an endocrine disorder or an endocrine disease. So first of all, we'll see about the pituitary gland disorders. We'll see about the disorders one by one. First, we move on to the pituitary gland disorders. So the pituitary gland secretes the growth hormone. The growth hormone is of vital importance for the normal growth and development. Hyper and hypopituitarism both have a marked effect on the development of orofacial structures, including eruption and shedding pattern of the teeth. Growth hormone hypersecretion results in gigantism and acromegaly, and growth hormone deficiency or hyposecretion results in dwarfism, which leads to growth retardation in children. So first we'll see about gigantism, and these are the clinical features of gigantism. Gigantism is characterized by striking clinical features that specifically appear before puberty. Patient is more than 80 inches tall, the body is well proportionated, have a thick build and broad spanning hands. And the other disturbances include the patient may have headache, visual disturbances, and signs of diabetes mellitus and osteoporosis are common in patients with gigantism. The liver, spleen, kidneys and other internal organs also enlarges. So next one is the acromegaly. So the clinical features of acromegaly include enlarged hands and feet, enlarged facial features including the facial bones, small outgrowths of skin tissues which are also referred to as the skin tags, fatigue and joint or muscle weakness, pain and limited joint mobility, a deepened husky voice due to enlarged vocal cords and sinuses, and headaches which may be persistent or severe in some cases. There are some oral manifestations which are related to the hypersecretion of pituitary glands. The skeletal and dental changes include frontal bossing, overgrowth of soft tissue produces thick lips, tongue and epiglottis, hoarseness of voice and dyspnea, reduces the airway diameter which makes the patients more susceptible to upper airway obstruction. To summarize, there are the clinical features of gigantism and acromegaly. In gigantism, the teeth size are proportional to the generalized enlarged body size. There is interdental spacing, dental malocclusion and hypersymatosis of roots. And in case of acromegaly, the patient will show thick and negroid lips, enlarged tongue which is referred to as a macroglossia with indentations on the lateral border of the tongue because of the enlargement of the tongue, an enlarged prognathic mandible, class 3 type malocclusion, enlarged nasal sinuses and anterior open bite. So these are the general dental features of hypersecretion of pituitary gland. So the next one is the hyposecretion of pituitary gland. This hyposecretion of pituitary gland results in dwarfism. The patient will manifest with large head and short muscular arms, small stature, and the facial growth is slow. And the dental features include delayed eruption rate as well as delayed shedding of deciduous teeth, smaller clinical crown of teeth, smaller roots with retarded growth of supporting apparatus and smaller dental arches, crowding and malocclusion, retarded growth of mandible and fine wrinkles around the mouth and eyes. So these are the dental manifestations of dwarfism. So far we have finished about the pituitary gland disorders. So under pituitary gland disorders you have both hypersecretion and hyposecretion. Hypersecretion results in gigantism and acromegaly, and hyposecretion results in dwarfism. So now we are moving on to the thyroid gland disorders. So as you all know, thyroid is an endocrine gland which is situated at the roof of the neck on either side of the trachea. It has two lobes which are connected in the middle by a structure called as isthmus. And weight of the thyroid gland, it usually measures about 20 to 40 gram in size. So there are few hormones which are secreted by the thyroid gland. The tetraiodothyroxine, also called as the T4, triiodothyroxine, also called as the T3, and calcitonin. So these are the main hormones which are secreted by the thyroid gland, and the synthesis of thyroid hormones occurs in the following steps. First, there is thyroglobulin synthesis, followed by iodine trapping, oxidation of the trapped iodide, iodination of tyrosine, and the coupling reactions, and finally the thyroid hormones are synthesized. So first we will see about hyperthyroidism, also referred to as the THYROTOXICOSIS. This is nothing but the hypersecretion of the thyroid hormones. So hyperthyroidism is a hypermetabolic state resulting from excess secretion of thyroid hormones, that is T3 and T4, and most frequently caused by a diffusely hyperactive thyroid gland, also known as a diffuse toxic goiter or the Graves' disease. So goiter is nothing but an enlarged thyroid gland that produces a visible swelling which you can see in the anterior part of the neck. So when you see the patient clinically, you will be able to appreciate the swelling which is situated in the anterior part of the neck. So the etiology for Graves' disease, it can be due to autoimmune disorders, it can be familial, it can be due to thyroid stimulating immunoglobulins, exophthalmos producing substance, or it can be simply due to emotion and stress. So there are some clinical features which are specific to hyperthyroidism, which include brood over the thyroid, diarrhea, exophthalmos, also called as a lid-lax sign, heat intolerance, hyperactivity, muscle weakness, nervousness, palpitation and tachycardia, sweating, tremor, warm skin, and weight loss. So these are the general clinical features of hyperthyroidism. Yes, now we will see about the oral manifestations of or dental considerations in patients with hyperthyroidism. There is early exfoliation of the primary teeth and early eruption of the permanent teeth. There is increased metabolic activity of the tongue, and on rare occasion a patient may exhibit thyroid tissue along the path of thyroglossal duct within the oral cavity. When it is seen on the tongue in the area of the foramen cecum, it is referred to as the lingual thyroid. Yeah. Next we will move on to the hypothyroidism. So far we have seen about hyperthyroidism and the clinical features of Graves' disease. So now we are moving on to the hyposecretion of thyroid hormones, which is referred to as the hypothyroidism. So hypothyroidism is a deficiency of the thyroid hormone, is a rare hypometabolic disorder, 5 times more common in women than in men. It is divided into 2 categories according to the age of onset. In infants and young children it is called as cretinism, and in adults it is referred to as a myxedema. And the picture on the adjacent picture will show you the signs of, signs and symptoms of hypothyroidism in general. The patient will have intolerance to cold, there is receding hairline, facial and eyelid edema, dull blank expression, extreme fatigue, thick tongue, slow speech, and the patient will show signs of anorexia. There is hair loss, apathy, the skin is extremely dry and coarse, muscle weakness, and constipation. Constipation is one of the very important clinical features of hypothyroidism. So in children it is referred to as a cretinism. The hypothyroidism in children is referred to as a cretinism. So the patient will exhibit short stature, severe mental retardation, coarse facial features, protruding tongue, and umbilical hernia. And in case of myxedema, when the hypothyroidism is seen in adults, it is referred to as a myxedema, and the clinical features are edematous appearance throughout the body, swelling of face, bagginess under the eyes, non-pitting type of edema, and atherosclerosis. So these are the oral manifestations of thyroid disorders. You have hypothyroidism and hyperthyroidism. So under hypothyroidism, there is salivary gland enlargement, compromised periodontal health and delayed bone resorption, macroglossia, that is enlargement of the tongue, glossitis, that is inflammation of the tongue and pain over the tongue, dysgeusia, there is alteration in taste, delayed dental eruption, enamel hypoplasia in both the dentitions, anterior open bite, micrognathia, thick lips, and mouth breathing. So these are the dental manifestations of hypothyroidism. So coming on to hyperthyroidism, the patient may have increased susceptibility to caries, increased susceptibility to periodontal disease, enlargement of the extraglandular thyroid tissue, burning mouth syndrome, accelerated dental eruption, maxillary and mandibular osteoporosis, and development of connective tissue diseases like Sjogren's syndrome or systemic lupus erythematosus. So these are the oral manifestations of both hypothyroidism and hyperthyroidism. So hypothyroidism in children is referred to as cretinism, and in adults it is referred to as myxedema. So far we have finished seeing about pituitary gland disorders and thyroid gland disorders. Now we are moving on to parathyroid disorders. So the parathyroid glands, they consist of 4 small glands which approximately measuring about 3 cross 6 cross 2 mm, which are paired at upper and lower poles immediately situated posteriorly to the thyroid gland. So the functions of the parathyroid glands include they produce and release the parathormone, which is important regulator of plasma concentration of ionized calcium. This ionized calcium is again essential for bone and tooth development, neuromuscular excitability, membrane fluidity and integrity, cell communication and cell adhesion, and blood clotting. So the hypersecretion of parathyroid gland results in hyperparathyroidism. This hyperparathyroidism leads to excessive production and secretion of PTH, which is called as the parathyroid hormone, consequent osteoclastic resorption and hypercalcemia. The clinical features of hyperparathyroidism includes the patient may exhibit musculoskeletal problems, genitourinary problems, cardiovascular problems, gastrointestinal disorders, and neuropsychiatric disorders. So these are the clinical features of hyperparathyroidism in general. Yeah. Next, moving on to the oral manifestations of hyperparathyroidism. The dental abnormalities include obliteration of pulp chamber by the pulp stone, alteration in the dental eruption, loosening and drifting of teeth, malocclusion, spacing of teeth, and loss of lamina dura. So these are the dental abnormalities which you see in a patient with hyperparathyroidism. And the other findings include brown tumor, also called as a brown tumor of hyperparathyroidism, soft tissue calcification, hypercalcemia may result in silolithiasis, and complaints of vague jaw pain. So we will see about the brown tumor in specific. The brown tumor is a bone lesion that arises in settings of excess osteoclast activity such as hyperparathyroidism. So they are a form of osteitis fibrosa cystica. It is not a neoplasm, but it is a mass rather than a neoplasm. So this is a radiographic picture, a hand wrist radiograph, and you can see the well defined corticated radiolucent lesion in the proximal phalange. You can appreciate the well defined radiolucency here, and this is referred to as a Brown's tumor. You can see the radiolucency here also, and this is called as a Brown's tumor or osteitis fibrosis cystica. Yeah, here is an orthopantomogram. You can again see a well defined corticated lucent lesion in the body of the mandible. You can see a well defined radiolucent lesion here, and this is an example of Brown's tumor in an orthopantomogram. Yeah, here again is a periapical radiograph showing the ground glass appearance and alteration in the trabecular pattern, and this is an occlusal radiograph. This shows a multilocular radiolucency which is characteristic of brown tumor of hyperparathyroidism. Yeah, next we are going to talk about the hypoparathyroidism. This hypoparathyroidism is characterized by low level of blood levels of parathyroid hormone. So the common causes of this disease is accidental removal or damage to the parathyroid gland during thyroidectomy surgeries. So that will be the most important reason for hypoparathyroidism. So these are the clinical findings of hypoparathyroidism, which includes tetany, stiffness, muscle spasms, numbness and tingling, hypocalcemia, Chvostek sign, Trousy sign, memory lapses, seizures, emotional liability, nail deformities, and cataract development. So these are the clinical features of hypoparathyroidism in general. Yeah, next is the dental manifestation or the oral manifestations of hypoparathyroidism. So these are the things you can appreciate in a patient with who present to the dental department with hypoparathyroidism. Enamel hypoplasia, delayed eruption of teeth, multiple unerupted teeth, hypoplastic pitting, microdontia, and the roots of the teeth are often short with blunt ends, and a delay or cessation of dental growth and development. Severe dental caries is usually noted in the deciduous and permanent teeth. Yeah, the dental manifestations of parathyroid disorders are to maintain the adequate serum calcium level, and patients whose condition is brought under medical control can receive the routine dental treatment. There need not be much modifications in their treatment procedures. So that's the end of the parathyroid gland disorders. Now we are going to see about the adrenal gland disorders. The adrenal glands are small paired endocrine glands about 3 to 6 gram in weight, located at the posterior superior pole of each kidneys. So anatomically, each gland is divided into the inner medulla, which secretes the catecholamines, and the larger outer cortex, which secretes over different steroid hormones. So these adrenal glands, they basically secrete the steroid hormones. So hypersecretion of adrenal glands results in Cushing syndrome, and this picture will show you the clinical features of Cushing syndrome in general. The patient may have hyperglycemia, there is central nervous system irritability, fluid retention, thin extremities, gastrointestinal distress, which is because of increase in acid, and females may have amenorrhea and hirsutism, thin skin, purple striae, bruises, and petechiae. And there can also be personality changes, moon face, which is characteristic of this Cushing syndrome. There is increased susceptibility to infection. Males may exhibit gynecomastia and fat deposits on the face and back of the shoulders, and there is osteoporosis. So there are some oral manifestations and dental considerations in Cushing syndrome. The patient's face is usually round, swollen, reddish, and have acne. The gingiva is enlarged, swollen, and bleeds easily. Despite the tendency for osteoporosis, no bony abnormalities of the jaws are usually noted, and the periodontal and candidal infections may occur. The patients are more susceptible to the development of periodontal and candida infections. Dental management of patient with Cushing syndrome, there should be regulation of the steroid level before treatment, whether it is going to be a minor or major surgery. Patients who take corticosteroids after adrenal surgery may require supplemental dosage during the dental appointment, especially during times of surgery, to avoid the adrenal crisis. Patients with Cushing disease may have weakened respiratory muscles, which predispose them to the respiratory depression. Sedative procedures that suppress the ventilation should be avoided in patients with Cushing syndrome. So next is the hyposecretion of adrenal gland, which is referred to as the Addison's disease. So hypersecretion of adrenal gland causes Cushing syndrome, and hyposecretion of adrenal gland causes Addison's disease. Adrenal insufficiency is a term used to describe inadequate glucocorticoid or mineralocorticoid production. So in Addison's disease, it is caused by autoimmune destruction of the adrenal gland, and in some cases adrenal insufficiency is caused by tuberculous infection of the adrenal gland, adrenalectomy, gram-negative sepsis, which leads to bilateral adrenal hemorrhage. So these are the clinical features of Addison's disease. The patient may have pigmentation of skin and mucous membrane, muscular weakness, dehydration with loss of sodium, hypotension, hypoglycemia, nausea, vomiting, and diarrhea, inability to withstand any stress resulting in adrenal crisis. The next we'll talk about acute adrenal crisis. This is a life-threatening state which is caused by insufficient levels of cortisol. Causes may be due to exposure to even mild stress, hypoglycemia due to fasting, trauma, surgical operation, and dehydration. So these are the main causes for acute adrenal crisis. There are some oral manifestations and dental considerations in adrenal crisis. There is diffuse melanosis which occurs on the tongue and gingiva, lips, but lips are less frequently involved. Diffuse epidermal hypermelanosis in the presence of weakness, lethargy, and hypertension mandates a referral to the physician for a complete physical evaluation before you are going to proceed with the dental treatment. Yeah, the next we are moving on to pancreatic disorders. So we have finished about seeing about adrenal disorders, and next we are moving on to pancreatic disorders. The pancreas is unique in that it acts both as an endocrine and an exocrine gland. The dual function of secreting hormones into the blood, endocrine, and secreting enzymes through the ducts, which is referred to as the exocrine. So pancreas have both the functions of exocrine and endocrine glands. The endocrine component of the pancreas consists of islet cells, also referred to as the islets of Langerhans. There are two main types of pancreatic hormones which are secreted by the Langerhans cells, which is insulin. This hormone acts to lower the blood sugar level, and the other hormone is a glucagon, which acts to raise the blood sugar level. So when we talk about pancreatic disorders, the main disorder which is taken to account is diabetes mellitus. It is a chronic metabolic disorder characterized by relative or absolute lack of insulin. Diabetes mellitus is a chronic disease that produces multiple systemic complications and is the 7th leading cause of death in United States. So the normal range of blood glucose in the fasting state is 70 to 100 mg per dl. Pre-meal state is 90 to 100 mg per dl. 1 hour after meal is less than 130 mg, and 2 hours after a meal is less than 120 mg. So this is the scale by which you can measure the levels of blood sugar in a patient who is presenting with diabetes mellitus. There are two types of diabetes mellitus. You have type 1 or the insulin dependent diabetes mellitus, and the type 2 or the non-insulin dependent diabetes. The clinical features of type 1 include glucosuria, polyuria, nocturia, polydipsia, weight loss and weakness, and polyphagia. So these are the clinical features of type 1 or the insulin dependent diabetes mellitus. And the next is the type 2 diabetes mellitus, which is non-insulin dependent. This is mostly seen in obese patients after the age of 40 years. Patients with type 2 diabetes may claim to have a touch of diabetes. The signs and symptoms are hunger and thirst along with pruritus or a dry mouth. The patients are overweight, but occasionally they lose weight because of this disease. So these are the clinical presentations of diabetes mellitus. So in case of eyes, there is diabetic retinopathy, cataract and blindness, and in the kidneys, there is diabetic nephropathy or renal failure, and in the nervous system, both the sensory and autonomic disturbances occur. So when it comes to the sensory, there is peripheral neuropathy, cranial neuropathy affecting the cranial nerves 3, 4, 6 and 7, and the autonomic changes include changes in the cardiac rate and rhythm, the dysfunction and gastrointestinal neuropathy. When it comes to skin and oral mucosa, they are more susceptible to infections, and there is delayed wound healing. And when it comes to the periodontium, the patient may have gingivitis and periodontal disease. And in cardiovascular system, there is macrovascular disease leading to peripheral vascular disease. There is coronary artery disease, cerebrovascular disease, and gangrenous feet. So these are the, as diabetes is a multi-system disorder, these are the clinical features of diabetes mellitus. There are some specific oral manifestations which are characteristically seen in diabetes mellitus. These include xerostomia, the burning mouth syndrome, gingivitis and periodontitis, periodontal disease and tooth mobility seen in more than 70% of the cases, multiple caries tooth, xyle adenosis or xylosis. The patients are more susceptible to candidal infections, which is seen as a white pseudomembrane inside the oral mucosa. And diabetic gingivitis can produce peculiar proliferation of the exudative tissue that arise from the marginal and attached gingiva. And the well demarcated swellings are soft, red, irregular and hemorrhagic. And the dental considerations in diabetes mellitus, the patient may also have denture sore mouth and angular cheilitis. Less frequently it causes median rhomboid glossitis. There is slow wound healing and dry socket, also referred to as the alveolar osteitis, which usually occurs following 3 to 5 days after extraction. Oral ulcers and open wounds may persist despite normal therapy. Patient may have acetone breath, large soft calculus deposits around the tooth, decreased muscle tone of the tongue and increased salivary viscosity. The saliva seems to be very sticky. The patient will have xerostomia. And Greenspan syndrome, this is reported in the literature as a condition of diabetes mellitus along with erosive lichen planus and hypertension. So the triad of diabetes mellitus, erosive lichen planus and hypertension is together referred to as a Greenspan syndrome. Okay, that's the end of our class, and these are the references I use for this presentation. I thank all the students for patient listening of my class. Thank you.